Hello and welcome to the University of Queensland Faculty of Health and Behavioural Sciences Alumni Webinar Series. My name is Paul Purcell and today we'll be joined by Professor Trevor Russell from the Recover Injury Research Centre. Professor Russell is the Centre Director for Recover as well as the Co-Director of the Centre for Research in Telerehabilitation. He has been researching telehealth for 20 years and has a special interest in utilising and developing technology that will enable enhanced service delivery within health and more specifically rehabilitation. I begin today by acknowledging the traditional owners and their custodianship of the various different lands on which we all meet today. On behalf of the University, I pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society. For those of you joining us live today, you're encouraged to ask questions during the webinar. There's a Q&A function that you'll find at the bottom of your screen. You're very welcome to use that and ask questions, and we'll endeavour to get to those towards the end. This webinar is also being recorded and will become accessible via the HaBS Alumni webpage. This and all other episodes in the series have been stored there, and we will send a link to this after the event. And now, it gives me great pleasure to introduce Professor Trevor Russell.
Great, thank you very much, Paul, and thanks everyone for joining me today as we talk about telehealth at UQ. We're going to have a look at telehealth pre-COVID, how COVID has affected what we're doing with respect to telehealth at UQ, and then have a look to the future and see where we're heading with respect to telehealth technologies at UQ. So thanks very much for joining me. Hopefully you can see the slides on your screen and that you can hear me clearly. Just wanted to start by saying that at UQ, we have had a long history of engagement with telehealth. So for the better part of 20 years now, back in 1999, the University of Queensland established the Centre for Online Health in the HaBS faculty. And soon after that, we established a Centre for Telerehabilitation in particular in 2004. More recently, we've established a telerehabilitation clinic, which I'll talk a little bit more about during the talk. But we have had a long involvement with telehealth and we've been very productive in the research. So together with all of the various parties that research telehealth at UQ, we're #1 in the world in terms of the number of publications in this space. So a lot of knowledge around telehealth at UQ more broadly. My background is physiotherapy, so I grew up, as it were, in the School of Health and Rehab Science. So I'm going to be, in this talk, talking specifically about rehabilitation. So we'll look at the rehabilitation aspects of how COVID has impacted what we do. Just by way of definition, so telerehabilitation is all about just providing those rehabilitation services at a distance using electronic information and communication technologies. So it's using a various number of different technologies, such as real-time technologies, so video conferencing, doing those real-time video consults, and that can happen between hospital facilities, for example, or it can happen between a practice and someone's home. Utilizing store and forward technology. So maybe these are software packages whereby we can prescribe exercises remotely to patients. They can be doing those in their own home and copying video clips and so forth. It also encompasses things like monitoring. So using consumer devices to monitor how people are moving or what they're doing in the home environment. So there's a whole lot of different technologies that are wrapped up in telerehabilitation or the provision of these rehabilitation services remotely to people. And it's fairly obvious why we might want to do something like that in Australia. So Australia is an extremely big place. As you can see on this map, I love putting this slide up. You can see just how big Australia is, yet we've got a very small relative population that's distributed over that large geographical area. So providing access to care is certainly one of the biggest drivers that we've had to telerehabilitation here in Australia, but also around the world. There are lots of other drivers though. It's not just all about accessing care, it's accessing the right care, so accessing specialist care, for example. It's addressing things like the aging population. So how do we continue to provide the high quality of health services that we're all used to into the future where we've got higher proportions of people that need access to those services, particularly rehab services. And there's a whole host of other things that you can see on that slide. Just the advent of technology provides a driver for us to use that and leverage that to provide care. And the benefits then that can come are really derived specifically from those drivers. So from a benefits perspective, obviously patients needing to travel less, take less time to access care, can actually be safer for some patients to receive care in their own home. So if they don't have to travel, if they're very unwell, having to not have to travel to a metropolitan centre, for example, can be a safer way of receiving treatment. The very nature of telehealth means that it does promote self-management. So people are having to take more ownership of their health. They're having to do more of their treatment themselves. So if you think about something like a physiotherapy consult, you're not able to put your hands on anymore. So it's not a passive treatment anymore. They've got to achieve their outcomes through things like exercise and self-applied management techniques. So it promotes self-management, and that gives people the opportunity to take more control of their rehab. So that's a positive thing. Of course, it's convenient and allows continuity of care. So as people move, they can access the same clinicians who have got their history. So continuity of care is a big piece. Decreased environmental impacts then through the reduction in travel and the reduction in the need to establish outpatient services. So over the years, we've been doing lots of research in this area. So this is all pre-COVID, and we certainly have done research looking at things like assessment. So can we do assessments of patients remotely using these technologies and get the same answer, the same diagnosis as we would have if the patient was standing in front of us in our clinic where we have access to all of our various pieces of equipment? So there's been quite a lot of work done over the years, and this is just to show one research paper, a systematic review that had a look at 11 different assessment or diagnostic validity studies. And through that systematic review, we're able to say with some confidence that we can do assessments of various things with a high level of confidence. So things like range of motion and muscle swelling and balance and gait and functional assessments. These are all physiotherapy type things. So this is a physiotherapy example here. But these papers showed us time and time again that if you use the technology right and you had the right protocol, you could come up with the right answer. So you were getting the same diagnosis as if the patient was with you face-to-face in a clinic environment. On the treatment side of things, our research started to show that treatment was quite successful as well. So we would conduct these randomized controlled trials where we would have a group of people, half of them would receive the conventional in-person treatment, which is the gold standard in our practice, and half of them would receive then treatment purely via telehealth. So they would use things like I mentioned before, things like exercise and self-management, and we'd teach patients how to do things themselves. And the research started to throw up some fairly surprising results. So in this one randomized controlled trial, we found out that not only was telehealth not inferior to in-person treatment in terms of the outcomes that we were able to achieve, but in some of the outcomes, we actually found better results in the telerehabilitation treatment arm, which is certainly something that we weren't necessarily expecting, but it was a very positive finding. And this isn't a finding that we only found in our research. This was replicated around the world. This is an example of a systematic review and meta-analysis that one of my students did then, looking at 13 of these similar studies, over 1,500 people. And when we look at all the results with respect to physical function and disability outcomes, you can see in this forest plot on the screen here, anything to the right of this vertical line indicates that the outcomes were actually more favorable in the telerehabilitation arm of these randomized controlled trials. So as the evidence started to build, it gave us good confidence that, you know what, the outcomes aren't inferior to conventional in-person treatment, but in fact, they may actually be superior in some cases. And we think that may be because of that, you know, that greater self-efficacy, that greater responsibility that patients had to play in their own rehabilitation. So these were quite positive results. And we saw this not only in physio, I've been giving you physio examples because that's what my background is, but we're seeing that in all different areas of rehabilitation practice, in speech pathology, in occupational therapy, and audiology, and nursing, and dietetics, and nutrition, and even dentistry, and occupations like that, pharmacy. So we're seeing that sort of across the board, that outcomes were not really inferior, both with respect to assessment and treatment. So that led us in the School of Health and Rehab Science to establish a telerehabilitation clinic. And the purpose of this was to educate our students in this new form of practice, this new area of practice, not only just in a knowledge sense, but in a practical sense, so that the students would actually deliver care to real patients using technology under the supervision of clinical educators. And in doing that, we were training up the next generation of practitioners in how to really leverage this technology and leverage this different model of care to be able to provide care to patients out into the community and give them greater access to care. And the model of service really that we established in this clinic is that we would have students in the clinic, in this specialist built clinic, and we received philanthropic funding to build this specialised clinic. So we had students in the clinic with clinical educators who are providing supervision to those students, and the patients then were either in their own home, or we had contracts with schools, for example, to provide rehabilitation services into the school. So this then became a clinic which was part of a host of clinics that are offered by the school in physio, OT, speech, and so forth. So that was all what was happening in the past. And then this came along. So COVID came along, of course, and we all know the story of COVID and the response of countries closing borders, and then we had social distancing and shelter in place orders. So very quickly we came from an environment of status quo that we'd had to many years to this sort of thing. People isolated at home, trying to work with, kids jumping around, jumping on top of us. I'm sure we've all experienced some element of that over the last few months. But this became the new norm. And of course, that's difficult for a university where we've got particular requirements for our students in our health disciplines in terms of clinical experience, so clinical practice hours, for example, experience in different areas of practice. And one of the ways, of course, that we achieve those clinical practice hours is through the running of those university clinics that I had just mentioned. So all of a sudden we rely on these clinics. We can't, though, put our students in these clinics, and patients aren't attending those clinics because of those restrictions in COVID. There were a couple of things happening outside of the university sector, which are really important developments here. So we had our professions jump on board very quickly and develop telehealth guidelines, sourcing content from all of that previous research that I had talked about that's been done over the past 20 years or so. We also had policy change in terms of the government providing reimbursement for services for some disciplines and some patient types, and the private health insurers jumping on board, offering reimbursement for some services as well. So with that came the recognition that, hey, telehealth here might be a solution to our particular practices, which can no longer interact with people in the way that they have up until this point in time. And out there in our public health system and in private practice, this is the sort of response that we saw. And these are some numbers from Children's Health Queensland, the number of telehealth consults that they did within physiotherapy, comparing 2019 to 2020. So you can see 2,500% increase, for example, in April. So massive uptake of telehealth out there in the private sector. And as a university in our clinics, we followed suit. So this was an announcement on our School of Health and Rehab Science website saying all of our clinics now, we're going to telehealth, and our services are going to be available via telerehabilitation. Not just that telerehabilitation clinic that I had mentioned, but all of our other clinics were now saying we're going to do some telehealth to try and help us to get through this. And we did have support by the regulators. So again, just one example from physiotherapy, but this is our Australian Physiotherapy Council. You can see the words there in bold talking about the fact that they are recognising that telehealth clinical education is recognised as a valid way of providing that clinical education to our students that they need to be able to graduate at the end of the year. So a very important development. So I mentioned all of the clinics then started embracing telehealth within our school. So we saw, you know, the traditional model of service, which is where we had a clinical educator with a student within our clinics at UQ, providing services to patients either in their homes or schools. Increasingly during the COVID era, it was in their own homes. But we had to be fairly innovative in our approach as this whole COVID unfolded, the restrictions unfolded. So we had to get inventive. So we had circumstances where students couldn't come to university. They couldn't attend, either because they were under lockdown themselves or because they physically couldn't travel to the university. So we started to innovate, and we had models where we had the clinical educator at the university, the student in their own home, and the patient in their own home. So 3 different locations that we joined via a multi-point video conference then to enable the student to be able to provide that service to the patient with that oversight of the clinical educator at the university location. And we had to evolve even more after that. So when we got to the point where some educators couldn't travel to the university, we had some situations where educators were in their own home, students were in their own home, and patients were in their own home. And again, linking all of those parties together via technology to enable us to continue to provide those clinical services. And we got even more inventive than that with some of our international students, for example, who were stuck overseas. So students stuck in Canada can't travel back into Australia because the borders have closed. We were able then to do things like have students being international in their own home, educators in their own home or at the university, still providing those services to our Australian clients. So some very different models of care evolved over this COVID period. And just some numbers on that then, between 30th of March and the 1st of June, this was some statistics from the health and rehab clinics. So 1,280 occasions of services, so over 350 individual clients accessed care via telehealth. If we compare it to this time last year, about a 300% increase. And keeping in mind, we already had a tele-rehab clinic up and running at full steam last year. We sort of tripled our telehealth consults. We went from sort of single-digit clinical educators providing supervision via telehealth to 36 different clinical educators. So if you think about that, it meant that 36 educators had to be fully trained in how to supervise students via telehealth, actually how to practice via telehealth to be able to supervise the students in the first place. So a great amount of work by our team in SHRS in order to upskill people in a short period of time. We saw some pretty interesting statistics as well. So we usually have about a 25% did not attend or no-show rates of clients in our clinics. So a fairly high number of people just don't turn up. That reduced from 25% down to 5%. So all of a sudden, when you can dial directly into someone's living room, they don't have as many reasons for not attending services as they can come up with, perhaps when you're offering an inpatient service where they have to travel, when they have to try and find parking on a busy university campus and all of those sorts of things. So that was a really positive thing. But the highlight piece here is that during this COVID period, 180 students were able to continue their clinical education placements that otherwise wouldn't have been able to do so if we weren't able to ramp up this telehealth effort very quickly. And potentially then 180 students who wouldn't be graduating at the end of the year because they wouldn't have met their clinical education requirements. So that's a really positive thing that we're able to pivot very quickly. We're able to pivot very quickly because we already had those services in place and we already had that experience on how to deliver telehealth. But then teams coming together rapidly, bringing on board telehealth services into those existing clinics. And we've done some research around this. Of course, there's a great opportunity for research. So we've got a project now where we're looking at the client's experience with telehealth. We're also looking at the students' experience in telehealth. So these were students who were expecting to go to a face-to-face service, and all of a sudden they're trying to deliver services via telehealth. So what was their experience in this? And also, what was the perceptions of the clinical educators? And we wanted to know how they perceived it. Did they like it? Did they not like it? They're not the people who would have chosen it outside of COVID, but they were forced into it. So we really want to understand what their experience is. To date, one of our researchers, Megan Ross, has done a whole series of interviews, then 27 with clients, 13 with clinical educators, and 9 with students to date. This is just a snapshot of some of the results to date. Overall, very positive. So clients very grateful that they can continue to receive services, even though they're in, confined to their own homes. Some excitement that it's better than expected, both from educators and students and client perspective. Some feeling that there was comparable to in-person services when it came to doing things like patient interviews and rapport building. It's not all smooth sailing, of course, so some assessments and treatments difficult to do, but able to evolve different treatment methodologies to get clinical outcomes still. Very interestingly, all said that they would recommend this to families or friends or others that need services during this time, and that they would engage in this in the future. So I think overall some pretty positive responses, not just from the clients, but also from students and educators who were kind of thrust into this at a moment's notice. So I think you'll agree that they're fairly positive findings there. So as Bob Dylan said in his song, the times are a-changing. Times are a-changing here with what we do in the future as well. So what are we looking forward to? I think, with the experiences that we've had, things aren't going to go back to how they were pre-COVID. The successful implementation, I think, will impact upon our clinical offerings. The educators know a lot more about this now, and they're experienced in this, so it gives them greater confidence in thinking about when to use telehealth services. And also we have patients' demand, so more and more people now know about telehealth and they've had good experiences with it, and that's likely to drive demand in the future. We're looking at more hybrid offerings. So once things return more to in-person services, being able to do some sessions in person and then supplement that with telehealth is a very attractive model. So maybe it's some follow-ups that you need to do with a child that you're offering OT services to, and you can just dial into them in their own homes after school to do a quick follow-up session. So the idea of doing lots more hybrid telehealth in our clinics is very attractive. We've got a whole new curriculum which has come online, so 53 modules about how to do telehealth in clinical practice, which is being embedded into our various health programs here at UQ. Will be available to all of our different health programs at UQ. So that's something exciting, which is likely to continue the education of our students and really be a differentiator for UQ graduates out there in the greater community. And of course, all of this generates lots of research opportunity for how we successfully implement and make sustainable services in telehealth. So I think that's just a brief snapshot. It's a fairly whirlwind tour of where we were pre-COVID, what happened during COVID, and where we're looking to go into the future after COVID starts to resolve, particularly from the perspective of a rehabilitation service at UQ at very least. So at that point, if there are questions, I think we have some time to go through any questions that may come up that people want to ask about. I realise that I went through that very, very quickly, so welcome questions.
Thank you so much, Trevor. That was absolutely fascinating, and we do have a few questions that have come through. So if you've got the opportunity, I'll fire a couple at you, and we'll see if we can work through them.
Absolutely.
The first one I've received is actually references when you mentioned that UQ is leading in a world leader in this space. The question was, how have other universities approached this?
Yeah, so a lot of other universities, when COVID hit, they scrambled. So they didn't have telehealth services. They saw what was happening out there in clinic land, where people were just starting to adopt telehealth services very rapidly, And it was very intuitive that they either needed to do the same things themselves in their existing clinics, or else their students were going to be in that situation where it'd be very difficult for them to graduate. So we have seen a very rapid scramble of universities around the world. There's been lots of these sorts of webinars that I've been on in an international perspective, and not just me, of course, but many others providing the know-how in how to adopt telehealth fairly rapidly in a safe and in an effective way to deliver telehealth services. So it hasn't just been us at UQ that's done this. We have had a bit of an advantage in that we had experience in doing this, but there's been a lot of universities out there who have experienced a fair amount of pain, but they have been very successful in adopting telehealth within their clinical offerings as well.
Right. Our next question we have here is, I've found some discrepancies in the use of different concepts in the literature, such as telehealth. Some use it as the use of digital health by a health system. What would be the most appropriate definition from your perspective?
Yeah, so definitions are a bit grey, I suppose, in this area, and they are evolving too. So in the past, digital health involves everything from electronic medical records to telehealth activity can be considered digital health, monitoring is considered digital health, all sorts of health informatics, so dashboards and insights about disease and clinical support systems, all of that falls under a bit of a banner of digital health. Telehealth narrows it down a little bit, which is more, telehealth is more about the provision of health services remotely using technology. And then you tend to have terms that are specific to discipline areas. So I've been using the term telerehabilitation today, which we tend to use within the rehabilitation sciences, not exclusively. We have professions like speech pathology who call it telepractice. But then we have other disciplines like radiology calls theirs teleradiology or telepathology or telepsychiatry. Telehealth, though, is seeming to be used more and more, even within professions like physiotherapy, as a bit of a catch-all term. So we don't need to get into definition too much. I think we're going towards telehealth as fairly well the universal term that's being used in the health sector to describe this sort of activity.
Great, thank you. We have another saying, what were the limitations and experiences back at the beginning of the implementation of telehealth that other countries could use to implement this in their area?
So the limitations to the implementation?
That's correct. Yes.
Yep. There's quite a few. So from an implementation perspective, training is a big one. So if we're talking clinical education, it's providing that training to the clinical educators. And with telehealth, there's a certain amount of skills that are associated with it and not just knowledge. So it's not just giving them a manual to read about how to do telehealth, that you do need some hands-on experience in how to do that so that you can know how to adapt what you would conventionally do face-to-face to an online environment. So there's a large piece of training in there in upskilling people to be competent with how to deliver it. Getting the technology in place is a big piece. Deciding what platform you're going to use, whether it conforms to all of the relevant security requirements that's appropriate within that particular country that you're delivering it in is a big piece. Getting the required support from a technology perspective is really important. And then developing up those resources that you need, because you need to inform clients about it. You need to provide them with handouts and instructions about what they need to do on their end. You need to devise systems of how do you get consent from the patient, seeing they're not with you. There is issues of referrals sometimes. We're very well set up for doing paper-based referrals, but not digital referrals. So there are a whole host of considerations that are incremental barriers that you need to skip over in order to establish this service. What this has given us the ability to do, the COVID experience, is we are now doing research where we're going out to organisations and saying, right, what were the pain points? How would that have been made smoother for you? What could we have done? Or what if it was in place would have made it easier? So we're doing a piece of work now with multiple services to try and tease out what were those stickiest points and how can we address those effectively for implementation going forward.
Great, thank you. From your early findings from research interviews, can you comment on the relationship development between patient and provider during telerehabilitation sessions, especially when they hadn't met in person prior to those sessions?
Yeah, I can. The preliminary results that we've got, this is something that has come up, and it's been fairly obvious in all of our interviews that we've had with patients and students and educators. And I would preface all of that by saying the literature for the last 15 years has given us a good picture of this as well, in that rapport building isn't influenced that much by doing these sorts of consults via telehealth. So the literature tells us time and time again that you can build rapport via telehealth. It is effective in doing that, and I'll give you a brief example. So we did a research study for people with heart failure, where we're delivering heart failure rehabilitation to people in their own homes, and we're doing that in a multi-point fashion. So we've got 6 people all in their own homes, spread across the state. We've got one physio or facilitator who's delivering that rehab program. Because people are in their own living rooms, we had this really nice dynamic dialogue of people being able to pick up pictures of grandkids off the shelf and show people on the camera, and really have the sort of social interaction that they would normally have in a clinic environment. But it was almost enhanced because they're in their own environment, they're in their own home, and they feel comfortable in their own home. And it's almost like they're inviting other people into their home when we're doing these sorts of consults. So we see that rapport building is definitely not inferior when we're using these technologies. And there are some occasions, again, where just because of the fact that people are comfortable, they're in their own home environment, there is a certain warmth that goes with that. So I would say that rapport building is one thing that you shouldn't be concerned about when it comes to telepractice.
Yeah, I think we've all experienced that on various levels. We've gotten to know one another's living rooms a lot better through the case of Zoom recently.
That's right.
And just to wrap up, we've got a couple of different people have asked a question along a similar theme, so we might use this as our final question. With respect to training of clinical educators, and also, actually, let me rephrase that. Do you think that clinicians should go through a formal training? And if so, what do you think that should consist of?
Yeah, absolutely. I think it's really critically important. I've seen lots of good things over COVID of people trying to implement telehealth very well. I've also seen some things that I would have rather have not seen in terms of clinicians going out there, picking up the first technology they can find and trying just to go about doing things without education. There is a level of education which is, I think, very important, and it's around the sort of ethical and professionalism aspects of it that you need to get right. You need to be doing things in a safe way that meet all of the relevant requirements of the health consult, that meets privacy requirements, those sorts of things. So there's a level of knowledge which is really important, I think. I think education then extends into best practice in how to go about achieving the best results for your patients. And one of the things that that all of us that have been working in this area for many, many years have always embraced is the fact that a telehealth consult should not be inferior to an in-person consult. And in order to ensure that, I think there's a level of training that's needed in how to go about it safely and effectively that all clinicians really should have. There are more and more offerings of this now, and they've sprung up a lot during COVID. There are online courses that you can do that go through the fundamentals of it. And there are some CPD type things that are starting to come about now to upskill people. But I think there is that sort of level of training that needs to happen before people really just run into this headlong. But there are, as I said, there are options out there now. There are education options, and they are in-person options available.
That's fantastic. Thank you, Trevor. We really appreciate your time. We've had quite a few comments coming through thanking you as well. So at that point, we might bring the webinar to a close. I'm very grateful once again for you taking us through all of this about telerehabilitation and explaining some of the past, present and future. And I look forward to seeing how it continues to develop. For those of you who joined us live today or speaking on behalf of colleagues, we will send out this link as soon as it's available. It may come out Monday. We might be able to get it out this afternoon. It will just have to depend. So thank you once again, and we look forward to seeing you again in the future. Thank you.
Thanks, everyone. Thanks for your time today. Appreciate it.